What makes me really proud to work with the team here at WCMICS is that through our active engagement and partnership with our health services and our consumers, we get to work hand in hand to deliver safe, accessible and quality care to those affected by cancer. Not only working towards better patient outcomes, but a commitment towards ensuring better patient experience. So how we are achieving this is through our active collaboration, innovation and facilitation with our health services and our consumers, ensuring that we keep the patient at the very centre of everything that we do.
Good afternoon, everyone. Welcome to the annual WCMICS Sharing event. We're going to be sharing and celebrating some achievements from the last year or so. For those of you who don't know me, I'm Michael Barton. I'm the Quality and Performance Manager at WCMICS. So first I'd like to acknowledge the Wurundjeri people, who are the traditional custodians of the land upon which we meet today. I'd also like to pay respect to the elders, both past and present, of the Kulin Nation, and extend that respect to any other Indigenous Australians present. So this afternoon we're going to take a look at the year of 2018, showcase a few highlights of the WCMICS funding programme. We'll hear from a number of our esteemed project leads as they share with us not just the why of their project, but the impact that those projects had in the quality of the care that our patients received. So at the end of, after those projects, WCMICS will be launching a suite of patient self-education resources for men with prostate cancer that came out of last year's prostate cancer optimal care pathways work. So more on that later. So I'd like to introduce Brian Lee and Stacey Panozzo, who are going to present on a project that's still ongoing about medicinal cannabis called Fact versus Fiction, Medicinal Cannabis, How to Decide. Brian is the Director of Pal Care at WCMICS and is a specialist in both palliative medicine and medical oncology, and is the current chair of the training committee of the Royal Australasian College of Physicians. Stacey is a research fellow at Peter Mac and WCMICS in the Pal Care Palliative Medicine Research Group. So please join me in welcoming Brian and Stacey.
Primary thanks to WCMICS for the invitation to speak today and for the fantastic support for this project and previous projects that we've been involved with. It's really lovely to come together and be able to share some of the highlights from our project and also hear the tremendous work that's being done more generally. So our project basically centres on the topic of medicinal cannabis, and to many clinicians, development of cannabis has sort of taken a cart before the horse approach, in that usually treatments have a very strong evidence base through various trials that have been done, preclinical and clinical studies, whereas many clinicians feel that medicinal cannabis has sort of come from a groundswell of popular opinion into the clinic rather than vice versa. And even this morning I saw an 86-year-old Italian woman who had ovarian cancer, and who I was talking about palliative care support, some symptom management, and she was telling me that she was feeling anxious and she was wondering about the role of CBD. And I was sitting there thinking, the last thing I want to do is be an idiot and say, what's CBD? Because I was thinking it was cognitive behavioural, CBT. Then I thought, I should talk about BDZ, benzodiazepines, and then it dawned on me she was talking about cannabidiol, CBD, and it was like, it just blew me away that someone, there's no stereotype of patient who I guess is interested in medicinal cannabis. And so just by way of background, there have been several changes, I guess, to legislation and the availability of what's called medicinal cannabis, particularly for patients with cancer, but also other conditions as well. We don't have a lot of established evidence to support its use though. So there is some evidence for chemo-induced nausea and vomiting. The studies that were being done were at the same time as people were studying the use of Stemetil. Do we still use Stemetil for nausea and vomiting and chemotherapy-induced nausea? No, we don't. So it just gives you an indication of a little bit of evidence there. Some evidence for appetite, weight, contradictory evidence for cancer pain use. There are 2 recent phase 3 studies published which showed no difference to placebo, but a pooled study that showed a trend but no statistical significance to improvement in cancer pain. Lots of people think that it might help to treat cancer specifically, and there's not a lot of evidence to support that. But we do know that a lot of people, both anecdotally, are asking about medicinal cannabis, and there's literature to support the thought that upwards of 2/3 of our patients might have already some knowledge and wonder about it, and the majority of these patients actually want information from their clinicians about it. And clinicians themselves want to know about what to tell their patients as well. So we put this to WCMICS as an area that all of the WCMICS organisations, and indeed across Victoria and maybe nationally, would benefit from information in this area. And we didn't want to just craft something that I could write on the back of my hand about, because there's already a lot of suspicion that clinicians perhaps are shielding information from patients. So we wanted to do it in a robust and rigorous way, and one that we could share with others through sharing the resource directly, as well as disseminating it through medical literature. So we did these 4 phases, established a project advisory group. The most important thing with any project is getting a fantastic project manager, and we found one in Stacey. And our goals were to understand what both patients and clinicians wanted to know, to improve their understanding, and also to try and get a handle on turning the anecdote into a record of fact. So how many discussions are we having? What are the discussions about? Are we going to meet the needs through this project, and what further work needs to be done in this area? So we talked to lots of clinicians, we talked to lots of content experts, we talked to people who write pamphlets and brochures about how technical it could be. We talked to lots of consumers, both uninvolved consumers, not from this project, but also had 3 consumers involved in this project, and really went through a whole process of, in a methodology called a co-design framework. We also had a project advisory group, which I think interestingly had people who were really interested in this topic, not just the consumers that I mentioned, but also people from the Department of Health and Human Services, the Medicinal Cannabis Office, people who could make decisions, and research fellows, and Michael as well from WCMICS. So Stacey did all this work, so it seems a bit rude of me just to present her work, so I asked her to come and talk to us about it. So Dr. Stacey.
So I'll just touch a little bit on the sorts of results we received, who we spoke to, and all those sorts of things. And I think without Brian, none of the participants would ever say yes to our study. So we looked firstly, we wanted to understand medicinal cannabis. What do people know about medicinal cannabis in cancer? What do patients and clinicians, what do they want to know about it? Who and when should discussions be initiated? Who should be involved? What do they think about the financial costs associated with medicinal cannabis? And especially for clinicians, we wanted to know what are their information needs around access and prescribing. This is all very new. It's an unapproved drug. There is quite a process involved in, a particular application process involved in accessing this for their patients. So we took a thematic analysis approach to the data. And to give you a sense of who we spoke with, we had 14 former or current cancer patients involved in focus groups or interviews. We had 2/3 female, both young and older consumers. We had just over half considered medicinal cannabis, however none had actually used it, although we did have a participant who talked about their self-sourced cannabis that they used during their treatment. For clinicians, we spoke with 10 palliative care and oncology clinicians, and they were quite experienced. 80% had over 10 years of experience in their clinical discipline, and 60% had experienced requests for medicinal cannabis from their partner. None had actually prescribed at that point. So I'll just touch on a couple of the topics and the sorts of things that were shared during those sessions. When we asked consumers about their understanding of medicinal cannabis and what they'd seen or heard or read about, many of them had heard about medicinal cannabis through movies, current affair programs, the newspaper, and different online sources. And one consumer, or many consumers, felt that the general population lacked knowledge about this medication. One consumer in particular indicated there's a lack of knowledge of what it is. The general public think that doctors are going to put it in a cigarette and give it to a child or something. Just such a lack of knowledge about how to administer it, what it is, and how the doctors do it. There was a big thought amongst our consumers that it's a natural treatment, far more natural than any other treatments for cancer or the symptoms associated. And some felt that information had been withheld from them. I had heard about it, I hadn't seen any proof. You can only believe 10% of what you read or you see on the net. But I really believe that pharmaceutical companies have always known about medicinal cannabis. When it came to clinicians, they discussed the issue of a lack of evidence around medicinal cannabis. That was quite key. We're talking about this as if it's a drug, but it's not actually a drug, it's a whole family of drugs. That's part of the problem, I suspect, from one clinician. There may well be some active ingredients in there that may well affect in some situations, but we have absolutely no idea because it's not a drug, it's a whole bunch of things thrown in together. And clinicians were clear that it's used when conventional treatments have been exhausted. It's not going to be your frontline nausea or your frontline pain medication. When it comes to actually what people wanted to see in an information resource, for consumers it was all about, one consumer was saying information is power, but you want to keep it simple and make it accessible. Another wanted to know, why cannabis? What's this got to offer me that other stuff doesn't, essentially? Another said what we need to do is cut down the stories, the tales, the misinterpretations to actually get a leaflet, some information out that states A, B, C, D, E, and F, it may not help you. So the kinds of things that they wanted in an information resource was history about cannabis. Why cannabis? What is this drug? They wanted to broadly know what sort of research and evidence was out there. How confident could they be in this particular medication type? Could it work for me but not somebody else? They wanted to know side effects, addictive properties, long-term consequences. Cost was a big one because it's not on the PBS, so they want to know about that. They wanted other people to know about that as well. And a contact phone number. They don't just want to read about it, they want to talk to someone. They wanted that option to be able to contact someone. And also having a reliable number of websites that they can actually go to after this 2-page introduction to the medication. For clinicians, they shared that it would be good to have something with as much information for patients as possible, considering this topic, as Brian's already indicated, this topic where patients come really distrusting us. They think we're the gatekeepers who are refusing to give this miraculous drug and that we only dispense the negative information and withhold the truly positive stuff. There is too much us versus them going on. They also wanted to be clear that medicinal cannabis in this particular resource development, that it's not a cure for cancer, it's not subsidised by the government, so again that issue of cost was key, and that patients can't drive when they're on this medication, so safety issues around the drug. For their own information resource, because we're developing one for clinicians, one for patients, so for theirs, they wanted to know how to apply for this particular medication, what products are available, what's the dosage and administration, the clinical trials that might be available, and how do we tap into that sort of information while the patient's in the room in the consult and interested. side effects, interactions with other drugs, and the sorts of precautions they need to be aware of. So they were the sorts of things that they thought were key for their resource content. Interestingly, although clinicians were very clear that they wouldn't consider medicinal cannabis at any early point, consumers expected quite differently and thought it should be brought up, like the way that any treatment is brought up by a doctor, if it's an option now. For aesthetics and logistics, clinicians and consumers felt it important that there were branding and badging suitable on this patient information resource, enough to build confidence in where it's coming from and what it's sharing. Make the resource available in paper form and online, and perhaps for a future study it was a bit beyond the scope of ours, but to have further consideration for different culturally diverse groups, how they may interact with the resource, how they may interact with the topic or the medication itself as a subject, and how they would receive that sort of information. So the patient information resource ended up addressing the following areas. Important areas that were informed from existing research evidence, from the Australian government guidance documents, from our focus groups and interviews, and our advisory group members. It was quite a review, edit process to really refine it, and also to get it to a point where the content's really easy to read. Our general population need a reading level of year 7 or 8. They're slightly different areas of focus, but again, meeting the need that was clearly identified when we spoke to different clinicians. So once we'd gone through all this process, we really wanted to know if it was actually going to hit the mark for patients. So we actually went to 2 different hospital sites and spoke with different patients. We spoke again, funnily enough, with 14 patients. They were palliative care patients across 2 hospital sites. 2/3 were female, most were over 56, and there were roughly a 50-50 mix of cancer patients and carers and family members who shared with us. And we had some positive results. We found, we firstly talked with them briefly about their previous understanding, and none had used medicinal cannabis before. They had considered it, about 30% had considered it, 36 had at least sought a little bit of information out about it. And 2 patients disclosed their previous self-sourced cannabis use. So we then gave them the information resource and we left it with them for 20 minutes, half an hour, and came back to find that 85% really agreed that it was easy to understand, 93% thought it answered their questions really well, 100% would recommend it to others, other patients, other carers. There were 36% who said, I think there's information missing. So I sat with them to find out what that sort of information was. A lot of the suggestions were a bit beyond the scope of the resource, or the evidence was lacking. So they wanted it to, a person who'd previously used a recreational source wanted it to say that it wasn't addictive, but we weren't quite able to really put that in there. Or that another patient wanted it to be specific to their cancer type, and the research isn't just out there for it to be that specific. So yeah, we have our clinician resource feedback coming in the next 2 weeks. We have 4 presentations across our site and we'll get clinical feedback from them. And we have resources available to share so that people can have a look, both the patient information resource and the clinical one. And I'd just like to acknowledge WCMICS, because without their generous support we wouldn't have been able to undertake the project and have these resources available to share across these multiple sites. And our consumers, patients and our advisory group.
Can we thank once again Brian and Stacey? So next up is Cameron Grant. He's the acute leukemia clinical nurse consultant at the shared heme service of the WCMICS, Royal Melbourne and Peter Mac. So please join me in welcoming Cameron.
once again, I just want to take the opportunity to thank WCMICS for their ongoing support during the project period. It was quite valuable to our patients, and it's great to see that what we sought out with the project is implemented now in just about everyday practice. So my name is Cameron, I'm the acute leukemia CNC for the Royal Melbourne Hospital and Peter MacCallum Cancer Centre, and I was also one of the nursing project leads for assessing haematology care in the home. So aspects of medicine, haematology has seen the flow-on effects from an ageing population. We've certainly seen an increase in the amount of patients being diagnosed with the haematological malignancies, and with that we now have a variety of treatment methods for the age spectrum as well. So depending on the patient's treatment intent, we certainly have supportive care being offered. We have low intensity or high dose chemotherapy being offered, clinical trials, immunotherapy, and then bone marrow transplants. So as we are now starting to treat more patients with a variety of different treatments, those patients are then requiring inpatient beds for their supportive care needs, whether they remit with a fever, symptoms associated with their treatment such as nausea, vomiting, diarrhoea, or acute kidney injuries as well. We're requiring more inpatient bed stays to try and treat that. We already had a working relationship between the Royal Melbourne Hospital and the Hospital and the Home Service. They'd previously been administering chemotherapy for some of our bone marrow transplant patients. So with this project, we'll certainly be able to build upon that already built relationship and try and explore new areas that our haematology patients could receive care whilst in the home. During the 2016 year, the Royal Melbourne Hospital and Peter MacCallum merged their haematology department, and with that we're broken up into tumour streams. With the Royal Melbourne Hospital took on the acute leukemia patients, and Peter MacCallum provided the care for the myeloma patients. Certainly the merging of the hospitals and haematology service certainly provided some challenges throughout the project period, but it also certainly offered up some opportunities for growth. So the stream service very much allowed a single focus of improvement. We were able to just narrow down and just focus on the care of leukemia patients. We were able to focus on the care of myeloma patients and see what we could really do to benefit this patient population. Probably from a reflective point of view, once the streams merged, we probably weren't as prepared for the increasing patient populations that we achieved on both sides of the bridge. And certainly this is just a trend of acute leukemia patients that have been diagnosed at the Royal Melbourne Hospital. We certainly had an increasing trend of 5 to 10 per year, but certainly after the merger in August 2016, we had a spike in diagnosis. And during the calendar year of 2018, we had 96 acute leukemia patients diagnosed. Not all those went to treatment course, but once again, with those ever increasing numbers, it just highlighted the need to sort of be innovative with our care to be provided. So much like the movie The Field of Dreams here, it was very much a case of build it and they will come. And that's certainly what we got with the new building. We started taking referrals from very much across Victorian, New South Wales, Tasmania. So trying to accommodate those was certainly a bit of a challenge and added increased pressure onto us. So the protocols developed with the haematology and health services had a mix of chemotherapy administration but also supportive care for the patient, and deliberate care was taken with these protocols to ensure safe administration with our hospital and the home team, that we could have good recruitment into those protocols, and then this could be replicated across other services. So just to go into a little bit, the Melphalan autologous stem cell transplant protocol, that was actually delivered across 3 phases. In phase 1, a patient was cared for by the hospital and the home team for 2 days after they had high dose conditioning and then received their stem cells back into them. During phase 2, they were cared for 5 days, and then for phase 3 actually included the whole entire transplant process, except for the stem cell administration, which was administered in apheresis. The hybrid chemotherapy protocols were designed where the chemotherapy administration would actually commence on the inpatient ward, but then halfway through would then transition to the hospital and home setting. So we did have a bit of a strict criteria for the hospital and home admission, and that was basically a safety reason. We wanted to ensure that the patients that we were sending to the hospital and home service were fit, well, going to be responsive to their own body, and basically highlight if they were feeling unwell and escalate their own care. So we had a process where the haematology consultant that oversaw the patient's care had to agree to consent to hospital and home. The patient obviously had to consent to the HIS-based programs. They had to fulfil the Royal Melbourne Hospital and the home admission criteria, such as living within 30 kilometres of the hospital or 40 minutes. They mustn't have had an ICU admission during their induction therapy. And we used a comorbidity index score, an ACE27 score, which basically just assessed their sort of predictor of how they'll tolerate treatment. So simple things, if a patient had hypertension and was on medications, we gave them a score of 1, and that was enough to deem them not safe to be with their hospital and home program. And once again, that was about building a safety profile and just ensuring that patients who were sent to the hospital and home were safe. They must have had home support and basically a carer who would be with the patient for the majority of the day, and mustn't have had a cognitive or behavioural barrier to participation. Key points to the majority of the protocols is that they would receive twice daily nursing visits. So in the morning, hospital and home nurse would go out to the patient's accommodation, whether that be their home or the supported accommodation close by. They would take daily blood tests of the morning, do a head-to-toe assessment then, and depending on the protocol, would then administer antibiotics or chemotherapy then. In the evening, there would be a further medical review, where a further nursing review, whereby they could implement some of the findings from the blood counts, so whether that be giving some fluid in the home, electrolyte replacement, or patient-reported symptom management such as some mucositis or nausea and vomiting, administering medications in the home. Once again, just trying to prevent them from readmissions to hospital. They would receive a daily medical review, which would either be in the home or via telehealth. We supplied them with an emergency dose of oral antibiotic, and this was, each patient was instructed to use if their temperature was greater than 38, or if they were feeling unwell, they were instructed to call the HIS nurse or the call, and if we deemed it appropriate, then we would get them to administer the antibiotic, take the antibiotic, and then come to hospital. So fever management, early use of antibiotics. Because it was the patient was considered an inpatient, we tried to do inpatient direct transfer and avoid the use of emergency department. And we'd also use the medical day unit, Peter McCallum as well. Once again, symptom management, providing IV fluids, electrolyte replacements, analgesia, the same care that they were, similar care to what they would receive in inpatient bed. In terms of transfusion support, it was almost like we would try and predict their needs as well. So try and predict for the following day, get the patient to come in for their blood transfusions, and then get medical review from a haematology or a bone marrow transplant consultant that day as well. It was important to note that when the patient was admitted, they were admitted under the hospital and home care. The leukemia stream and bone marrow transplant or myeloma stream just provided ongoing support there for them. So the patients were provided a 24-hour mobile number to call, so they always had support from hospital and home nurse and registrar. And that way, if they experience these symptoms out of hours, they would call the nurse and be instructed from there. So just to go through some of the results for our protocols. So the melphalan stem cell transplant, in phase 3 it has the potential to save 14 to 20 inpatient bed days. So phase 1 said was a 2-day stay, phase 1 was a 2-bed stay, phase 2 was a 5-bed stay, and phase 3 was the duration of the transplant, and then if they needed admission, going into hospital. So 62.5% of those patients actually required a readmission to hospital due to a variety of illnesses, mainly fevers, sometimes diarrhea post-chemotherapy, or developing flu early on in transplant. It's interesting to note that over the summer period we did actually have quite a significant amount of influenza cases. We had chemotherapy in the home for our acute promyelocytic leukemia patients, where they would have their arsenic administration on a Saturday and Sunday in the home. Ordinarily we'd have to admit them on a Friday evening or a Saturday morning back to the hospital for them to have their chemotherapy. Often we'd either send them back home overnight or they'd stay overnight, which is quite unnecessary for that patient population. And it was basically just a 2-hour infusion for the chemotherapy. So our consolidation chemotherapy for acute myeloid leukemia patients, unfortunately we weren't able to recruit into that protocol for a variety of reasons. We had a couple of times where we didn't have work for the hospital and home team on that side of town, so it wasn't feasible for them to go to basically the corner of their district when they didn't have work on that side of town for an afternoon visit especially. We had competing interests with clinical trials as well. We had one patient who was all prepped and ready to go, but unfortunately had a kidney injury, so deemed it wasn't appropriate to send them out and have hospital and home manage their chemotherapy. The neutropenic monitoring for acute lymphoblastic leukemias and acute myeloid leukemia patients was quite easily to recruit into. We had patients who had multiple visits with their under these protocols. Patients who had hypersever treatment for ALL, they would be on a 3-weekly treatment cycle, and their neutropenic duration was on average between 1 to 8 days. And we saw that only 45% of those patients recruited into actually had to represent back into hospital, and whether that be due to fever, nausea and vomiting. We had was tachycardic out in the community, had a high heart rate out in the community, didn't have any signs of other signs of fever, but we brought them in just for a matter of safety. He was an inpatient for 24 hours for further investigation and was discharged. Our acute myeloid leukemia patients, they tend to have a longer duration of neutropenic phase and have the potential to save between 6 to 18 days. And once again, 69% of those patients presented with fever, so common theme. Our early discharge on IV antibiotics, we weren't able to enrol into. That was a bit of discrepancies between practice across consultants, and trying to implement something that goes against the grain of what's normal. It's been a bit difficult. So overall, we had 4 protocols recruited into, which saved a total of 319 bed days, pretty much over an 18 months period once your accrual commenced. So just some take-home points: that chemotherapy administration is still a working project. We're actually working with our hospital and home team to develop the protocols for chemotherapy administration. Neutropenic monitoring or supportive care can safely be provided by hospital and home team, especially if you have the support of an ambulatory care setting and emergency department as well. That certainly is a protocol that's transferable to other streams or other services that may provide myelosuppressive treatment. And overall, patients were dissatisfied with receiving care in the home. Patient population who spends a lot of time in hospital anyway, to be able to spend more time at home with their family and loved ones was greatly appreciated by them. And once again, just thank you to WCMICS and our working partners at the Hematology Service.
Thank you, Cameron, and can we give a round of applause for Cameron again? Next up, we've got Genni Newnham from St Vincent's. Jenny's a medical oncologist, and in particular clinical interests include cancers of the lung and the GI tract and patient experience. She also provides specialist care for cancer patients in the Victorian prisons, which is what the project that Jenny's going to talk about is about. Please join me in welcoming Jenny.
So I'll echo everyone else's sentiments in thanking WCMICS for the support for the project and for the invitation to participate today. It's been really interesting so far. And yes, I'm going to talk about a project that we have undertaken exploring our population of prisoners with cancer. So I've been asked to try and focus primarily on why we chose to do this project and how it may be useful and for who, with less of a focus on the specifics of what we did, which is probably fortunate for me because our methods are pretty uninteresting, as CETA will know. Why to start with? So this is a cancer services forum, so I'm assuming that most people here have an interest in cancer and an understanding of the complexities in cancer treatment. We know that for optimal outcomes we need timely diagnosis and treatment, good multidisciplinary care and appropriate follow-up at all stages of the disease. Optimal care pathways, as everyone here would know, are guidelines, documents that have been established by expert groups in Australia, and they provide a good illustration of the key points of management in specific cancers. And they also include within many of the guidelines recommended timeframes within which each of those stages should occur. And we have referred very much to the optimal care pathways in our project. So why prisoners? So the available statistics describe our prison population as a vulnerable group with complex health needs. Prisoners have very high rates of chronic medical and mental illness, high rates of substance abuse, complicated by high rates of chronic viral hepatitis, high rates of homelessness and other forms of social disadvantage. There are international frameworks established by groups such as the United Nations and World Health Organization that stipulate that prisoners are entitled to receive healthcare that is equivalent to what the rest of the population receives. St Vincent's Hospital was established by the Sisters of Charity, whose primary mission was to provide compassionate healthcare to the poor and vulnerable. And in line with that, St Vincent's has been providing the bulk of tertiary healthcare to Victorian prisoners for some decades now. I personally have worked at St Vincent's for over 20 years, and so in that time have been involved in the provision of medical care to a large number of prisoners. And unfortunately, my experience in doing so is one of frustration. It feels as though every step is more difficult with this group of patients, starting with what are fairly trivial differences. So it's pretty inconvenient to access the secure ward, particularly when you've got a busy ward round. We often can't discharge them on the medications that we would usually like to send. But there are other more significant differences in this group. The patients with cancer are faced with a number of challenging decisions over the course of their illness. They need to make those decisions in the context of their diagnosis and prognosis, the likely risks and benefits of treatment, the likelihood of success of treatment. So when we see prisoners with cancer, we don't see them in the context of their friends and family and support network, like we do with other patients. Often when we see prisoners with cancer, they're accompanied by security staff, which is probably entirely appropriate, but it means that the conversations we have with these patients are less frank and detailed than the conversations we would often have with other patients. And consequently, we end up with a group of people who are less well informed about their illness and less engaged in their medical care. And certainly most of us who are involved in treating prisoners would, anecdotally at least, report pretty high rates of non-attendance and non-compliance. So they are a challenging group to treat. We know that our prison population is growing and ageing, and we know that cancer is largely a disease of ageing. So it's logical to assume that our need to negotiate the dual complexities of prisoner care and cancer care is only going to increase in the coming years. So with all of that in mind, we thought it would be a very useful exercise to explore and get a clear idea of the population of prisoners with cancer that we have been treating, make an assessment of whether that population is changing, and if so, in what way, and also make an assessment of how effectively we are delivering care to this group. So, the information that I have is really the result of two retrospective chart reviews that were conducted in parallel. The first generated a detailed description of the demographics and cancer information of all prisoners treated at St Vincent's Hospital over a 15-year time frame. The second, which is more the focus of today's presentation, was a much more detailed assessment of treatment timelines, adherence to the optimal care pathway recommendations, and then an exploration of potential barriers to care in a group of prisoners with cancer in a recent 5-year time period. So what we found was a group that was really very consistent with available statistics. We had a group of predominantly males, median age of 55, with proportionally high rates of smoking, illicit substance abuse, mental illness. The population is changing over time. When we compare our earliest 5-year cohort with the most recent, we can see that the number of prisoners with cancer rose from 39 to 104, and the median age increased by 10 years over that period of time. In total, we identified 221 cancers in 212 patients. You'll see that's more cancers than patients, and that's because 7 patients over the course of the assessment were diagnosed with either 2 or 3 separate primary cancers. And it was troubling to see that more than 3/4 of the cancers in this group weren't diagnosed until they were advanced enough to cause symptoms. So that's suggestive of a late presentation and an increased risk of poor outcomes. And consistent with that, 40% of the group had incurable disease at diagnosis, which is a pretty high rate considering it's a population with a median age of 55. There was a wide variety of cancer types seen. Those that were most commonly represented were non-melanoma skin cancer, lung cancer, colorectal cancer and hepatocellular cancer. And it was interesting to note that all of these cancers are at least in part related to lifestyle and exposures. Fortunately, we found that we had been meeting the majority of the optimal care recommendations for the majority of patients, and that include factors such as time from referral to appointment, time to completion of the diagnostic workup, appropriate discussion at multidisciplinary meetings, and appropriate referral to palliative care. Where we haven't been doing so well, however, is in time to treatment initiation. We found that 42% of this group did not start treatment within recommended timeframes, and these were all patients having treatment of curative intent, so the stakes are high. And in exploring further through the records, we found that in 55% of those people not starting treatment within recommended timeframes, it was due to non-attendance of some form. It was quite time-consuming trying to discover the reasons for non-attendance, and in many cases there was nothing documented in our files, so we remain unclear as to why those patients didn't attend. But where there were reasons documented, the vast majority were either due to patient refusal, and that's refusal to leave the home prison or refusal to transfer through Port Phillip prison, or due to a lack of available transport. So before undertaking this project, I really had very little understanding or no understanding of the complexity of prisoner transport in this state, and that's despite having worked at a hospital that treats prisoners for 20 years. So what I now understand is that in Victoria we have a number of regional prisons of varying sizes and security levels that are all marked on a map. They all have varying levels of nursing and medical support. Port Phillip Prison in Melbourne is a large high security prison which has a medical ward, has the highest level of medical and nursing support of our prisons, and serves as the central hub of prisoner transport or male prisoner transport in this state. So for any prisoner to come to St Vincent's for any reason, whether it's an admission or even just a blood test, they are effectively discharged from their home prison, which may mean losing their cell and their job. They are transferred by a secure bus to Port Phillip Prison, where they stay for a variable period of time until they are then transferred on to St Vincent's Hospital. At the end of their medical care episode, they're transferred back to Port Phillip Prison and then eventually back to their home prison. Every leg of that journey is dependent on sufficient seats on the bus, an appropriate mix of prisoners on the bus for security reasons, and security staff available for the bus. And the same system of transport is required for any prisoner transport, so court appearances and many other reasons that they would be using. So now understanding that and the size of our prison population, I'm now not at all surprised when prisoners don't turn up for our appointments that are made at fairly rigid and inflexible times. On top of that, Port Phillip Prison is a large high security prison. A lot of prisoners from the smaller regional prisons actually report very real fears for their safety at Port Phillip, and there certainly have been many instances of prisoners refusing any medical care at St Vincent's unless they could come without going to Port Phillip Prison. So how is all of that useful? Well, I think this exercise has allowed us to identify and very clearly describe a problem, and that is that we do have a growing and ageing prison population who are at risk of poor cancer outcomes. And they're at risk for a number of reasons. They have comorbidities, they have a tendency to late presentation, but there are also clearly system-related factors that are contributing to their risk. In thinking about the system-related factors, there are barriers within the hospital system and within the prison system. A number of those are resource-related and will be very difficult to modify. But what's also become apparent is that we really have two systems that are working effectively in silo. They're very complex systems with very different priorities that are at times competing. We have limited understanding of each other's requirements and limitations, and have had fairly limited communication between the two systems. So this knowledge has allowed us to make some changes in how we practice, and we've made some changes with the view to trying to reduce the requirement for prisoner transfer. So we're trying to do as many telehealth consultations as we can. We have those facilities available, and people just need to be educated in how to use them and do so effectively. And we're also trying to rationalise our appointment booking. So going through the records, we would see that a prisoner would be discharged on a Wednesday with an appointment to come back for an outpatient MRI the following Monday, which is what we do for other patients, but it clearly is not going to work with this population. We have certainly developed improved communication between the hospital and the prison system, and we've had a number of events where we've been able to sort of share and compare frustrations and have a bit of reciprocal education about our very different systems, and we have some more planned for this year. And I guess off the back of that, we're just sort of strengthening the working relationships between the hospital and the prisons. We have plans for more work. We think that this information really isn't specific to prisoners with cancer. It's relevant to any prisoner with a complex medical problem. So we need to educate our hospital staff, and unfortunately the hospital population is almost as fluid as the prison population. So we educate one lot and then they change and we get a new lot. So we're also looking at developing some practical resources to leave within the hospital. So who's going to benefit? Well, primarily I think the prisoners who are our patients, but there will be advantages to both the hospital and the prison system through increased efficiencies. And then ultimately, I guess, regardless of anyone's personal view on the rights of prisoners to healthcare, as taxpayers we're paying for whatever care we provide them, so it's probably in all of our best interests to make sure we're doing it in the most effective and efficient way possible. Thank you for attention. I've got my email there if anyone has great ideas to fix anything.
Thank you so much, Jenny. Thank you. So next up, we've got Anna Beaumont. Anna's a senior dietitian at Peter Mac. She's worked as a clinical dietitian for over 12 years in a number of tertiary teaching hospitals in Australia and the UK. And Anna's going to talk about Peter Mac's multidisciplinary optimization clinic. Please welcome Anna.
Thank you very much, and thanks for having me. It's exciting to share what at Peter Mac's been a fantastic initiative, thanks to WCMICS. So I'm going to touch on today the background to how this project became to be, the actual clinic that's been set up, and some results of the evaluation of our pilot clinic. And the clinic is ongoing as well, and we've done a further evaluation since that time. So going through some of that and some lessons learned. So it's well known that cancer and its treatments do cause patients to experience particularly malnutrition, substantial or severe fatigue, and ongoing pain post-curative cancer treatments. And we know that these negatively impact patient quality of life, their treatment outcomes, and their healthcare costs. The Australian and UK survivorship guidelines recommend the use of specialist services for complex patients arising from cancer treatment, and that having a comprehensive rehabilitation program is an interim step between acute treatment and rehabilitation has been recommended. And also we need to plan patients' rehabilitation needs early on in their acute treatment. Oops, I'm sorry, I'm jumping ahead. So based on this, we know that cancer patients with complex needs require a personalised, coordinated, multidisciplinary approach. So the Peter Mac Optimisation Clinic was put together to address these, and we were looking at patients going all through their treatment journey, through prehabilitation, their acute treatment, and post as well. We did benchmark our clinic on some others, particularly one in Montreal in Canada, and there's a couple of ones that are similar in Australia, and we were just looked at published literature, so there probably are more as well in pilot phases. So we looked at the lessons learned and some from what other places had done. So through our WCMICS grant, we piloted a clinic. It was April 2017 to April 2018, and we targeted lung and colorectal patients because our data and the literature shows that these are a particular cohort that do get complex issues. Our multidisciplinary clinic was set up with having a dietitian, a physio, a psychologist, and an occupational therapist. So the aim of our pilot project was to develop a model of care for our optimisation clinic and to improve the overall functional performance, psychological status, nutritional status, and fatigue level of the patients attending the clinic. So the model of care that we set up was that any clinician in Peter Mac could refer patients into the optimisation clinic, and we also got referrals through our electronic health questionnaire for all patients who are new presentation to Peter Mac. We had an allied health assistant who received these referrals, and they would screen the patient by phone. The reason for screening was to see whether they needed the multidisciplinary approach, whether they needed the different disciplines, but also the type of issues, whether they were deemed sort of complex that would warrant an 8-week program. So they rang and screened. The outcomes of the screening could be that they weren't eligible for any of the disciplines and they still got written information, and we got back to all the referrers about that. If they only needed one of those 4 disciplines, they'd be put into usual care, so they'd still be seen within Peter Mac but not in the optimisation clinic. But if they needed 2 or more, we'd invite them to participate in the optimisation clinic. And if they declined, they'd go into usual care, so they'd still get seen or invited to a scene in other areas of Peter Mac. Screening criteria were related to, psychology was related to depression and anxiety. The dietetics requirement was to do with risk of malnutrition and underweight. Physiotherapy was based on if they've got a falls risk or not meeting the International Physical Activity Guidelines. And the occupational therapy screening criteria are based on levels of fatigue and their degree of support care in their day-to-day activities. So it's a clinic that's one morning a week. The rooms are alongside each other for the different disciplines and the patient moves between one and the next. And often we do joint consultations with more than one discipline in there at once. They can attend up to 8 weeks, and it's tailored on an individual basis as to how many weeks they attend the clinic. And they're offered face-to-face or utilising telehealth reviews or phone. And the clinicians involved in each patient's care have a multidisciplinary meeting at the end of each clinic to discuss goal setting, coordinate the reviews, and start planning early for discharge if they need it into the community. So I won't go through these, but there's obviously complex and a lot of issues that cancer patients can experience within the different disciplines. So really the care provided was very much based on the individual, but the whole gamut of care that you'd provide complex cancer patients with. So from our pilot over was more like 9 months once we started the clinic, we had 62 referrals. We found that about 26% declined the screening, but for those that were eligible, we had 76% accepting being included into the clinic. Some of the reasons they didn't want to participate was that they felt well enough and they didn't want to come in and see the clinicians. Some of them already had seen clinicians and were well linked in, and we had the issue of them not wanting to travel because we did require them to come in face-to-face for their initial consultation so we could properly assess their needs and then offer telehealth for later on. Of the ones that did agree to participation, we had quite a high dropout rate, but looking at other cancer literature, it's equivalent dropout rates around 50% with cancer rehab programs that are over a number of weeks. And mainly it was declining condition or end-of-life care. So we learnt from this pilot a lot. We were focusing on why 25% didn't even want to talk about being part of this clinic, and the strict eligibility criteria that about half of them weren't complex enough or weren't what we thought was sort of severe enough that would be put into this clinic. So we made some changes. As well as looking at that, we did do some patient focus groups to find out their satisfaction and how they felt about it. And we got some really good feedback. Mainly, they identified that it was a convenience, especially coming in for multiple appointments in the one visit, they really liked. But they still appreciated that it was an individualised care and that multidisciplinary involvement they really appreciated as well. So what happened after our pilot? We had some other funding we sourced internally to do a 6-month sort of evaluation and really a sustainability project, we call it, to make our clinic roll into usual care. And that was always the initial plan, that we use the funding for paying for a project officer, but each of the 4 disciplines knew up front that they'd be staffing the clinic through current funding, but we knew it was shifting patients that were being seen already through separate discipline clinics to being seen in a multidisciplinary clinic. So we had some extra funding that the aims were to roll it out to all tumour streams beyond the lung and colorectal and to embed the clinic into usual care. We did that, we evaluated the model care, we did a lot of marketing and awareness raising beyond just the lung and colorectal tumour streams that were initially involved, and some training modules for clinicians about referring and who to put into the clinic. So we know that ongoing we'll be evaluating it and for quality purposes making sure the clinic's as good as it can be. So after this further 6 months, once it had been rolled out to all tumour streams, we set ourselves some KPIs, and this was reviewed in October, and we found that over the 6 months of rolling it all out throughout the hospital, we had on average referrals, 3.6 referrals per week, and we just pulled the 5 per week out of the air, thinking that sounds like a good number. But we found that it met our other KPIs, that of our spots available in the clinic, we were booking in to them, to 73% of them. But new patients, we wanted 1 new patient per week, and we were getting above that. Patient acceptability, we found that many more were wanting to be screened. We worked with our allied health assistant of how it was introduced and how it would be a benefit, and you were referred by your doctors, they want you to attend this clinic, and the benefits of it. So we had a lot of people saying, yes, please ask me the questions, this sounds like a great clinic that I potentially would want to go to. So that was really good. And in terms of when they were deemed eligible and invited to participate in the clinic, we had 71% accepting, which was around about our KPI, which was good. And we did want to look at reasons why patients said no thanks to being a part of the clinic, and a lot of them was again they felt well. Like on our screening, they might have had levels of fatigue or weren't meeting the activity guidelines, but they said, this, I've had it for so long, or it's not something that's impacting on their current life and quality of life, and so they didn't want to participate in a clinic to improve that. A lot of it again was the travelling into Peter Mac, and quite a lot were already getting services, which was fantastic to hear. But sometimes with a new diagnosis and having all their medical appointments, they reported they didn't want the stress of an extra appointment. So that's some of the reasons for declining. In terms of when we booked patients in, how many attended, we had a 68% attendance rate. And again, when reviewing our reasons for declining attendance, a lot of it was because they were too unwell. They'd been admitted to the ward in a lot of situations. So, justifiable reasons, that's not a factor of the service delivery, it's a factor of the patient population that have complex needs. So we wanted to look at how much travel time was saved by patients coming in for multiple appointments in the one clinic, and it calculated to be about 58 occasions of travel time saved because they were there for multiple appointments. In terms of completing their program, and again their program was individualised, we might have thought they needed 2 sessions to meet their goals, they might have needed 6 sessions to meet their goals. We looked at how many accepted the clinic, had their first appointment booked, but then never attended their first session, which was actually about a quarter of the patients, and a lot of it because they were admitted to the ward in that meantime. And it was usually about a 2 to 3 week period from being told, yes, we're going to book you into this clinic, to getting an appointment spot, because we had a bit of a waiting list. And some of them had already seen a clinician in the meantime, or had declined in their condition. We found 65% completed their prescribed program, and 20% attended some, so still got some benefits from the clinic, even if they couldn't attend further. So the dropout rates were equivalent, but what we also looked at were the number of patients who were initially referred to see some allied health clinicians, and 88% did receive some input, whether it was from written information or being booked into allied health outside optimisation clinic or within optimisation clinic. I mentioned about our clinical outcomes, which in the outset were part of our evaluation to see whether it helped medically and clinically these patients attending the clinic, but unfortunately our assessment outcome measures that we set up were functional measures, often about weight and body composition, 6-minute walk test, sit to stand. That wasn't, it was a burden, and it wasn't actually, it wasn't sensitive to their goals. They might have just wanted to get to the letterbox and back. So going through 6-minute walk tests and things like that certainly wasn't warranted. So we're actually looking into a new method of testing, whether it's a benefit to the patients in their meeting their own goals that are set at the beginning of their clinic visit, rather than looking at our functional status and things like that. But of the pilot project, we did measure these and we did look at them. So for our 14 patients in our pilot project, 10 of the measures, they were all either stable or improved. And that was the goal, that it was to prevent decline and to prevent more hospital readmissions. So things that we learned was that from the WCMICS pilot phase and rolling out this project, that we're still getting more and more referrals, and those referral rates are increasing. So it's, from a service point of view, the hospital is taking it on board really well. High rate of patient intention to try. So we're being introduced to the concept of the clinic, patients are interested in being screened. And a high rate of patient acceptance when they are screened and invited along, and that the qualitative assessment, the analysis of our focus groups and interviews shows that it was high patient satisfaction and acceptability. The efficient and convenience for the patients and also for the multidisciplinary team, and that improved coordination and communication was fantastic. And that there is dropout rates, but it is equivalent, and given our population of patients who have the complex needs have quite often progressive disease, that it is equivalent. Just my last slide, that from holding this clinic, we've been invited to give a lot of presentations. We've put forward abstract submissions to quite a few conferences to help share this learning with others. So in the last 6 months, we've done some presentations within Peter Mac with our Survivorship Centre, nutrition-based a conference in Sydney, COSA in Perth late last year, to the board, a case study. They were interested in hearing about patient experiences, GP and practice nurse forums, the Haematology Nursing Group, International Lung Cancer Conference, and we put an abstract yesterday for the MASK conference, a multidisciplinary supportive care conference in San Francisco next year. So, and I'll get regular emails, and you're welcome to email for any questions and insights as to how this sort of service can be set up in other facilities. Thank you.
Thanks once again, Anna. Thank you. So next up, we've got Martha Hickey. Martha is a clinical psychologist and professor of obstetrics and gynecology at the Uni of Melbourne, and holds adjunct positions at Harvard University and Peter Mac. She's also the director of the Women's Gynecology Research Centre at the Royal Women's. Please join me in welcoming Martha.
Thank you for inviting me. So I've come to talk about the project that was funded by WCMICS for women at high inherited risk of breast and ovarian cancer. So we wanted to develop some resources for high-risk women and also for the healthcare providers who looked after them. It was our clinical impression that there was a gap here, that women who were being advised to have risk-reducing salpingo-oophorectomy particularly were not really, didn't have enough information about the procedure and what might happen to them subsequently, particularly for premenopausal women. So we wanted to try and understand from the women what information they wanted, where the gaps were, also what was driving their decisions to have or to not have risk-reducing surgery, and similarly to speak to the healthcare professionals and find out from them what information they needed to help better support their patients. So just the background is that about 1 in 400 women carry a gene mutation that increases their risk of breast or ovarian cancer. And because of various initiatives, these haven't quite arrived here yet, but this is 23andMe and B4. These are postal salivary tests to have your gene mutation status tested, or targeted testing for people of Ashkenazi Jewish inheritance for family mutations. So more women are being tested. There isn't any screening for ovarian cancer available, so the only effective intervention at the moment that these women can do to reduce their ovarian cancer risk is to have their ovaries and fallopian tubes removed. But only about half of those women who are advised to have this procedure actually have it. So we were interested in understanding why that was, what the barriers were for those women. And some existing literature, there wasn't very much, suggested that surgical menopause, so the removal of the ovaries before natural menopause, was a limit, a barrier to women having the surgery. So surgical menopause, we actually don't know very much about it. There's a lot said that it's a very dramatic change in hormones for women, that the symptoms are worse, there's concerning data about long-term outcomes, but actual quality of the data is quite poor. And we were concerned that these are very frightening potential risks for women who are thinking about trying to reduce their cancer risk, that they may then be taking on higher risks of problems like cardiovascular disease or dementia later on. So what we wanted to do was to understand what the information needs were amongst high-risk women, and also amongst their healthcare professionals, and then we wanted to do something to address those unmet needs in terms of a resource. So when we looked around, first of all, to see what the existing resources were, there was almost nothing. We found one publication from New South Wales. Internationally, we found one publication from New South Wales explaining to women what was likely to happen after surgical menopause for high-risk women, and there was very little information there. We didn't really know why women chose or declined to have surgery. It looked like those women who'd had an immediate family member with ovarian cancer who died of cancer might be more likely to have the surgery, but again, it's all very vague. And there were no care pathways for women following risk-reducing oophorectomy. Once they'd had their cancer risk-reducing intervention, that was it, they were out the door. So what we found out when we spoke to the women to find out what information they wanted and what the barriers were for them to have surgery was that loss of fertility was a really big issue. And we expected that only women under 40 would be concerned about that, but what we found was that all the women, even up to the age of 50, were concerned that they were going to be losing their fertility. They were also concerned about surgical menopause, and they wanted to know, how is this going to affect me? When should I have the operation, and what can I do afterwards to improve my health in the short and long term? When we asked the healthcare professionals, they also identified very similar gaps. They didn't know enough about surgical menopause. They wanted to know more. They wanted to know more about the short-term symptoms, about long-term disease prevention, and they thought that this was the main reason women weren't having this, potentially life-saving surgery. So one of the outcomes of our project has been that we've developed new resources for high-risk women, and we've tried to address what the gaps were. So we've given information about the surgery, we've talked what is known about how surgical menopause impacts on women, we've given information about treatments that can be used, in particularly who can safely use HRT, and we've talked about long-term optimisation of health. And this is an example. This is the title page of the new resource that is for high-risk women, and I think I've just included some screenshots here of the different parts of it. Following feedback, we really started at quite a basic level to explain what the ovaries were and what they did and where they were, and what happened when you had this surgery. So we've been through various iterations of feedback with women and also with the patient resource people at the Women's Hospital to ensure that these resources have the appropriate level of readability and comprehension for patients. So we've also developed some new resources for healthcare professionals to specifically address what they wanted to know, the indications for the surgery, what might happen afterwards in the short and long term, and disease prevention. And what we found, and this is consistent with a little other literature, is everybody knows how much this operation reduces your risk of cancer, but they don't know anything else about it. So that was really the gap that we were trying to fill. And this is some screenshots from the resource that we've developed for the healthcare professionals. And again, this has been piloted in a wide range of professionals. What came out of this experience was the number of different people that were involved in managing a woman who was at high risk of ovarian cancer, and the lack of communication and streamlining between those different professionals. So that's our next project. So one of the reasons there isn't any information for high-risk women is because the information doesn't actually exist. And this is another project that I'm running called WHAM, which stands for What Happens After Menopause. And this is the largest prospective study of surgical menopause internationally. And we're collecting data on the outcomes of the surgery so that we're hoping we can update and improve the evidence base for our resources as time goes on. And this study's finished recruitment and we'll be reporting next year. So our evaluation, these are our criteria that we have addressed, and I'm not presenting all the evaluation criteria today because it's not quite all been done yet. As was mentioned before, the role of optimal care pathways in a cancer setting, we plan to take the same model and apply it to high-risk women who may not have had a personal history of cancer but still require that kind of long-term care. And these are the other issues that we will be addressing in the next WCMICS funded proposal. Thank you.
Perhaps you could give us a bit more detail on the new project and what that's all going to be about.
Yeah, thanks. So there's been a big change recently in who can do gene mutation testing, and it's gone from being something focused around clinical genetics, family cancer clinics, to now any specialist can do a gene mutation test. And as I mentioned, we're not far away from salivary tests through the post. And that's a good thing because women are aware of their risk, but it's a bad thing because actually what to do with that information, how it impacts on other members of the family, and risk assessment going forward isn't included. So part of the motivation for this study is to try and channel people who have positive test results into a system that will address those other repercussions of the diagnosis.
Join me in thanking Martha. Thank you. I'd now like to introduce Meron Pitcher. Meron's the head of the breast unit at Sunshine Hospital, and her research interests include improving quality of care for breast cancer survivors. And Meron's going to talk to us about primary care practitioners in the MDMs at Western. Thank you, Meron.
Thank you, Mark. So thank you very much for inviting me to speak, and also thank you very much WCMICS for supporting a project that's been close to my heart for a very long time. And basically the idea of this project is to try to work out how do we better engage primary care in our multidisciplinary management of patients. And I think it was, Jenny was saying earlier on about silos of public hospital and justice health. I think we often have silos within our own hospitals, but we've got major silos between hospitals, tertiary hospitals and primary care. And I think we've got to really remember that our patients have most of their care provided in general practice, and we are just a small little part of that, and it's really important that we acknowledge how important primary care is for our patients' management. The other thing, of course, is that as a selfish clinician, I see a lot of people who are thankfully well after their cancer treatment, and I want them to go back to their GPs to be encouraged to lose weight, get their blood pressure under control, to stop smoking and doing all those sorts of things. No, I'm not willing to do their pap smear while they're in my clinic. And to me, they don't really need to come to clinic. You know, it's nice for us to see people who are well and to reassure them, all those sorts of things, but we haven't got the resources, we haven't got the space, we haven't got the funding. And to me, it's so important that we engage GPs in the management of cancer on an ongoing basis. And we're all trying, I think, as clinicians, to encourage partnership and to encourage shared care. And if we're going to do that meaningfully, we need to engage GPs early on. Well, that's what I think. So that's really where part of the genesis of this project came from. So the question is, how do you do it? Because I think historically everyone thought cancer was terrible and therefore you had to be in a hospital, you couldn't possibly be looked after by a GP. And we know that the whole world of that has changed, certainly in my career. And so basically, I think we all are aware of what multidisciplinary meetings are about, and they've been part of the landscape for a long period of time. But the people who are clearly missing at multidisciplinary meetings are the patient. And I know there have been various ways and projects trying to engage patients at the meeting, but that's generally been regarded, I think, by everyone as too hard, and I think it's too hard. But we often ignore community practice and general practice. But I mean, the particular beauty to me of multidisciplinary meetings, if they're appropriately chaired and managed, is to give all the team members an opportunity to put in the benefit of their knowledge of the patient and their knowledge of the subject. And if we're making decisions about the patient who's not there, without the information from a community practitioner who has had a significant relationship with this patient, then we're really missing out on something that's pretty important. So the question is, again, how do you do it? Well, we went, I and the GP liaison officer as phase one of this went around knocking on people's doors and speaking to GPs and saying, what do you think? And they all sort of said, well, look, you're hopeless at communicating with us. Yes, we don't see that many cancer patients, but we really feel at sea, and they come and see us the day after they've seen you. We don't have a letter, and they're told they're going on a trial and they don't know whether they should do it, and we'd really like to be engaged in some shape or form. So I had a brilliant idea from someone that actually we could use to coordinate this. We could use nurse practitioners or practice nurses rather than GPs, but the feedback we got from phase one was that it really needed to be peer-to-peer with GPs, because the idea was to have a primary care practitioner, and that is a GP, attend the MDT. And that would be a generic GP, ideally from our area, who would be given a list of patients who were to be presented at the MDT several days before, and they would make contact with the identified patient's GP to see what information there might be. So they could advocate on behalf of the GP at the time of the meeting, and then hearing the conversation, they'd be in a position to feed back to the GP. And so that was really the way we wanted to set it up. And so the part of this project was that we had 2 tumour streams that volunteered, my stream, which is the breast stream, and the lung stream, which is again a big body of work at Western. And we were able to recruit 2 GPs who were enthusiastic to take part in this project. We had a reasonable amount of interest, and they were very engaged in terms of doing it. So what actually happened? Well, we did it over a 12-week period in the middle of last year. And you can see the numbers there. We had 194 individual patients discussed over that 12-week period. 178 178 GPs who belonged to those 194 patients were attempted to be contacted. And we got in touch with about 2/3 of them. So over 108 were able to be contacted. And there were some that were just unable to be contacted. Sometimes we didn't know who they were, or we had the wrong GP, which is pretty common. And there was a tiny percentage who were unwilling because they were too busy or they thought there were privacy issues. And then part of the project was to see how best to arrange this communication, because our preliminary work had said that some GPs wanted information by fax, some wanted to be telephoned, some wanted to be emailed, someone wanted a letter with a postage stamp on it, and they're a very diverse group, and to try to actually work out how to do that, and that was part of the job of the GP representatives when they made initial contact, saying the meeting's on Thursday, when would be a good time for me to contact you, how do you want us to do that? Most of the time fax was the preferred option, but in some it was by telephone. And one of the things that we're quite proud of is that we actually managed to get significant feedback from 35 out of those GPs. And those of you who've tried to engage general practice from a point of view of data and engagement, I think will recognise that that's no mean feat. And so really what did we achieve? What did we learn out of this? Well, what we learned, paradoxically, or I was clearly a bit naive or stupid or both, I actually thought that the input from the GP may well influence our decisions and treatment plan, but it wasn't very common that we found the GP representative told us something that we didn't already know. So we didn't actually learn a huge amount from that initial contact. But what we did discover was that the GPs found the information in a timely fashion and a relevant information given by a peer, so it was peer-to-peer information. They found that very helpful. They found it helpful in terms of knowing how to explain things to the patient and to really improve their communication and connection with us. Now, there were a couple of sort of highlights from information from patients, from the GPs to the meeting. On one occasion, they had a recent suicide attempt, which wasn't known to the unit. And so that clearly was something that was critically important for the team managing that patient. There was also a lung patient who was hyponatremic, and that could have led to a whole lot of investigations, but the GP representative found that the person had been recently on a particular diuretic, and so various things were saved in that space. We surveyed the team members who were at the multidisciplinary meeting, who were all very supportive of having a GP representative. I thought that it really enabled the team, who of course includes junior doctors, to really see the value of general practice. It highlighted them as equal partners in looking after patients, and it really gave us an opportunity to look at our systems about identifying the right GP and trying to work out how better to communicate in that space. So I think really the biggest benefit was not so much to us in terms of patient management, although it undoubtedly highlighted the important role of general practice. The GPs reported that they really appreciated the timely communication and increased confidence in supporting the patient. They did say that it seemed to be of more benefit, interestingly, for the lung patients, who tended to be an older cohort. So the GPs tended to have a better understanding of the lung group, whereas because the breast cohort had a number of younger women, they didn't necessarily have quite the same relationship with their GP. That was interesting, I thought. As I said before, peer-to-peer communication is clearly a much better way to go than a letter from me pontificating about how this patient might be treated. And it also gave our GP representatives an opportunity to explain some of the particular services that Western offers. And the Smart Clinic is our symptom management clinic for palliative care, or sort of another name for palliative care. And CIRC is our symptom urgent review clinic for patients on chemotherapy. And so it gave us, as an organisation, an opportunity to sort of educate our local GPs. And to me, the thing that made it all worthwhile was that one of the GPs said it broke the GP hospital divide, which I think is a large gulf that we really need to try to break. So I think we've demonstrated that this is an effective model to improve community involvement in cancer patients, as it enables timely and relevant two-way communication between the community and hospital care. The challenge, as always, is how to sustain this. From an educational point of view, good education for us as specialist clinicians and junior doctors in the hospital, excellent education for the GP representatives attending who really appreciate it as CPD. But if anyone's got any money, I'm very happy to have it. Thank you very much.
Thanks so much, Meron. So our final speaker is one of the WCMICS team. It's Mayuri, and she's going to talk about some work in the prostate cancer space, as I mentioned earlier. So please welcome Mayuri.
Hi everybody, and thanks for staying back at this busy room. I'm Mayuri, I'm the project officer, and I'm currently working in the OCP space. So a little bit of the background, as you, Jenny touched on the optimal cancer care pathways as well. There are national guides to the best cancer care for specific tumor types. So I won't go through the detail because I think all of us are across the OCPs. But as you know, they describe the key stages in patients' cancer care journey, from diagnosis to survivorship or end-of-life care, and the expected optimal care at each stage. So the primary purpose of the OCPs is to improve patient outcomes by facilitating consistent cancer care based on the standardized pathways. There's actually a slide missing here. The OCPs, we're currently, the ICSs are working on in the OCP program of work, and we are right now working in the tranche 3. And the first tranche we worked in the lung and colorectal space, and tranche 2 we worked in the esophagogastric and prostate OCP space. Today I'm presenting the solutions that WCMICS delivered for prostate. The gap analysis, so a little bit of a background of what we did. We did the medical record audit and consumer surveys and clinician interviews. And the gaps that we identified were that patients don't always retain the medical information that is given to them during clinician consultations. And they're also seldom given individualized information. A lot of times they're given generic information, leaflets about prostate cancer, but they're not given written individualized information. And that we found was an area that we could work in. As we all know, communication effectively improves patients' health literacy, and improving health literacy also improves the health outcomes. So what we did was, so the solution that we came up with was a prostate cancer care plan, which is actually on the next slide. What we did was co-design approach with the consumers, clinicians, prostate cancer nurses. We consulted them and developed the prostate cancer care plan. So across 4 major health services, which was Peter MacCallum, Royal Melbourne, the Western Health, and the St. Vincent's Hospital. The cancer care plan that was developed was actually for the lung stream, and that was piloted at the Royal Melbourne and Peter MacCallum. The prostate cancer care plan was developed on the lung, I would say, and we did co-design with the prostate cancer consumers from support groups as well. So we sought feedback from consumers, clinicians, and developed iteratively and developed the cancer care plan. So this is what the cancer care plan looks like. It's a single-page document with information, so double-sided. Information about the type of cancer, the doctors they will be seeing, the stage, the test on the first side, and on the second side there's information about the treatment plan, supportive care information on side effects, which I'll go through in a little bit detail after this. So basically, it is a suite of co-designed patient-centered information tools that will improve the clinician communication and also empower the patients. So this is the first section on the care plan. It talks about, so this is something that the clinicians or the nurses are expected to fill for the patients. So patient, on the first section is patient demographic details, which usually is a label, and the prostate cancer's type, stage, and the location details, cancer location, and any additional information that needs to be given to the patient. The bottom section is appointment details and any diagnostic test and staging test details. The second side, or the back side of the document, is the key contact person details from the hospital for the patient, the treatment plan or the proposed treatment plan for the patient, details of the side effects, and the bottom section is any questions for the patient about treatment, supportive care information, and any support service referrals made for the patient. So what's this next one? So this was the prostate cancer care plan that was developed, and it was successfully implemented at the 4 health services that we, and the 4 health services that I mentioned before. The second solution that WCMICS delivered in this space was the self-education media. Again, the gap analysis that we did was men with prostate cancer have various treatment options based on their, depending on their stage of the disease, the age, and any presence of comorbidities. However, these treatments typically have side effects, and supportive care is important for patients to manage these side effects. However, the supportive care information is not always easily accessible to patients, and especially for those who are having the non-surgical type of treatment. For patients with culturally and linguistically diverse background, again, the supportive care becomes very difficult because it's not easily available for them. So the aim was basically to provide accessible supportive care, self-education media on treatment options, side effects, pre and post-treatment, pre and post-treatment rehabilitation for men with prostate cancer. The topics that we covered were the role of general practitioner in prostate cancer care, androgen deprivation therapy and management of side effects of ADT, prostate cancer treatment options and side effects and how to manage the side effects, psychological support for men, exercise physiology, and the last one was the pelvic floor physiotherapy as well. So these videos are also being translated into 3 languages other than English, which were the top 3 languages in the WCMICS health services. So work for that is currently underway. These videos will be available on the WCMICS, rather they will be posted on the WCMICS website and available for distribution to patients. Consumers, we surveyed consumers in the testing phase, and we received a very positive feedback from them. The self-education videos basically they said that the self-education provided very comprehensive and complementary information about supportive care, and some of the key messages were that because there were a few patients who were previously diagnosed in the group, so they said they wished that these kind of videos were available when they were diagnosed, and great supportive care which was immediately required after treatment as well as in long term. So we would also like to launch the videos and show you one of the videos, which is the role of general practitioner in prostate cancer care.
My name is Dr Jane Crow and I'm a GP. For many men with prostate cancer, the path to diagnosis and treatment starts with a GP, when the conversation about prostate cancer testing takes place. For a man who has no symptoms suggestive of prostate cancer, current Australian guidelines recommend a man be informed about the benefits and harms of testing. This is so the man can then weigh up whether or not to proceed. This is called shared decision making, and advice is tailored depending on your age, the rest of your general health, and whether or not you have a family history of prostate, breast, ovarian or bowel cancer. However, for some men, prostate cancer is diagnosed after they present with symptoms that may be suggestive of prostate cancer. If you decide to be tested for prostate cancer, the first step is to have a blood test to check the level of PSA in your blood. PSA stands for prostate specific antigen and is a protein made by the prostate cells that also enters the bloodstream. If the PSA test comes back elevated, it suggests something might be going on in the prostate that needs sorting out. It could be infection, inflammation, benign enlargement of the prostate, or it could be prostate cancer. Your GP will arrange a referral for you to see a urologist. And when you do see the urologist is likely to examine the prostate via a digital rectal examination, and you may also be required to have an MRI to image the prostate. The urologist will then use the combined information of your PSA, the digital rectal examination, and the MRI to decide if you will need to have a biopsy of the prostate. The biopsy is when a sample of the prostate is taken by inserting needles into the prostate. The result of the biopsy will determine if there's cancer in the prostate or not. If cancer is found, there are two broad groups. The first group is if a small amount of very low grade or low risk cancer is found on biopsy. In this case, you may be advised not to have the prostate treated, as it is very unlikely to spread or cause you any problems. However, you will need to be monitored closely by a specialist by a process called active surveillance, just in case a higher risk cancer is found or develops. The second group is if you have a biopsy and a higher grade cancer is found and treatment is required. For most men, the treatments are surgery or radiation. And the Australian guidelines recommend you get two opinions, one from a surgeon and one from a radiation oncologist. This is so you can weigh up the pros and cons of both treatments before proceeding down the treatment path. Your GP can help discuss these treatments and provide referrals. If you would like even a second or third opinion, that is perfectly fine, and your GP can help to arrange this. A recent study in the British Medical Journal reported that continuity of care is associated with multiple benefits for patients. Continuity of care and holistic care underpin what GPs do. Your cancer specialists regularly update and communicate with your GP, and your GP is part of your cancer treatment team and can be there for you along the entire treatment path. If you have prostate cancer, here are some examples of where your GP could help you. In cases where localised prostate cancer has been treated at some hospitals, you might have some of your follow-up appointments shared between the hospital and your GP, and this is called shared care. And the hospital cancer treatment team communicates clearly with your GP about what is required. Also, if you have localised prostate cancer that has been treated, some hospitals will discharge you back to your GP after a period of time for ongoing follow-up. Again, the GP will know what to do. In other areas, your GP can provide ongoing support and education of what is going on with your treatment and discuss treatment options with you as they occur. Your GP might administer some of the injections if you are on the androgen deprivation or hormone therapy. Your GP can be a first port of call for any concerns, side effects or psychological distress, and can give advice regarding the impact of the diagnosis and treatment on you and your family members. They can work through problems or any concerns relating to work, accessing appointments and treatments, and so on. Your GP can also assist with referral to allied health practitioners, for example, continence physiotherapists, exercise physiologists, psychologists, and they can also help to arrange GP management plans, team care arrangements, or mental health care plans. These are so you can access Medicare rebates for allied health and psychological counselling if required. Your GP can also help to liaise and coordinate your care with all your other treating health professionals, just like a hub and a wheel. Your GP can also help you to link into the local community resources and services and also gives them reliable online websites for further information and support. Importantly, the GP can keep an eye on the rest of your health, for example, immunisations, blood pressure, cardiovascular health, and other non-cancer related health conditions that may affect you.
That's really it. So thanks for staying back, and we're looking at the dissemination of these videos as well as the care plan. They will be available on the WCMICS website. So please have a look. Thank you.
Thank you very much. So I've just got a few of our future directions there on the projector. I won't go through them. I'd just like to thank everyone who's come today, our invited guest speakers, and everyone who's been involved with the projects, the consumers, the staff, and the other stakeholders who've made those projects happen. If you'd like any further information on any of them, please get in contact with any of the WCMICS team, and we'll put you in touch with the people in the know. So in closing, on behalf of the whole team, thank you very much for joining us.